To begin, I'm going to start with asking Dr. Ashley, what, if I were someone, what would a care journey look like? Well, if I went to the family doctor's office, what kind of questions would I be asked, or what would this first visit look like? What might I be offered?
Hello, everyone. So I guess the journey through the medical system, mainly from a primary care viewpoint, would depend on if you are coming to the office looking for advice or counsel or support on alcohol use disorder or other substance use, or if you are engaging in a visit from your family physician as a part of screening. So what I mean by screening is throughout your medical visits, whether you know it or not, we try to screen you for various things. So screen you for depression, screen you for marital issues, screen you for gambling addictions or substance use disorders, and that would include alcohol as well. So there are some ways that we go about trying to ask those questions in a non-judgmental, respectful way. If you do screen positive for, in this case, alcohol use disorder, we would ask your permission to discuss that further with you, and that gives us a sense on whether you want to discuss it or not, and that is up to you, and that is okay. And if someone's not ready to discuss it now, that's okay. I might ask you about it again next visit in a polite way, and maybe you're ready for it next visit, or maybe not, and that's okay. But maybe it spurs you on to start thinking about it more. Dr. Ashley mentioned alcohol. That wasn't even something that was on my mind, and now you hear something else from a friend, or you hear a colleague going through that journey, and now you maybe just feel that much more comfortable to come see us and have that discussion. So once you're at that point of, hey, we're sitting down today to discuss alcohol use, we have some criteria in the back of our mind to quantify the amount of alcohol you are consuming and label you with something, with alcohol use disorder. And I don't mean labeling in a negative way. When I say labeling you with, diagnosing you with a condition, the reason we diagnose people with conditions is because it really helps you as the patient and me as the provider to understand how I can best help you, or what are your risks associated with this condition. So in the setting of substance use disorder and alcohol use disorder, you have mild, moderate, or severe alcohol use disorder, and I have data that I can pull on to give to you and say, this is your risks associated with severe alcohol use disorder. This is your rates of cancer, likelihood of success with this medication or that medication, and it helps us understand how I can best support you, and hopefully helps you understand your condition and the severity of your condition. I think with alcohol use disorder in particular, people who consume alcohol regularly and maybe lack the insight to understand, or lack the insight that they are struggling with alcohol, it's usually because they're surrounded by people who are also consuming in the same amount. So I'll have various people come to my clinic and report that, oh yes, I know I drink 2 drinks every night, and oh man, I know I really need to stop, and I've been trying to cut back. And I have people come to my clinic and say, well, I only drink 12 beer a day, and but I don't start till after work, so it's okay. And so everybody comes at it from a different way and a different understanding of what the severity of their condition may be. So I guess that's a very long-winded answer to your question, but that is more or less how the beginnings of a discussion might look like with your family physician, and from there, trying to come up with a tailored treatment approach that best fits you, and what fits you and works well for you might not work for the next patient I see. And we try to lean on our other care providers as well to kind of augment that treatment plan, and our community members, family members, counselors in the community, to try to come up with a complete treatment plan that is tailored to you and your values and your wishes, and something that you think is going to be something that will work for you.
So if you wanted to elaborate on that, when you said different treatment options, what are some of those tools that are in the toolbox?
So, as was mentioned in the video, the newer tools in our toolbox are medication options, but other tools in the toolbox include counseling, psychological and emotional support from family members, friends. So that would be, not shaming someone, coming from a position of compassion and understanding, sharing your experiences and your successes, but really understanding what someone's struggling with and trying to support them through that. Exercise, treatment-based approach to managing addiction and supporting that way. Nutrition as well. There's one of the other medical advisory people with the CODS Society, actually from the United States, has a lot of expertise with treating alcohol use disorder from a nutritional standpoint. I don't, I'm not as educated on the topic as he would be, but he would be able to speak to that as well. And then of course the medications, which I'm getting the sense that we'll probably talk about lots, but currently there's 4 medications that are recommended by the BC Centre of Substance Use and the current alcohol use disorder guidelines, and there are others on that list too, baclofen and ondansetron as well, which are gaining more support as well, and we're starting to better understand the use of those medications. So usually we would start with, from treating most medical conditions, we have a guideline-based approach to treatment, and what we mean by that is just a framework for a physician to follow, and we're not all experts at every medical condition unless you're a specialist in that one disease. So the super specialists in that one disease kind of help general providers like myself come up with guidelines and a framework to start off with, and help us navigate the complexity and the new research that's coming out, and again, tailoring maybe a medical approach to your condition, and making sure that we're providing the best, most up-to-date care that we can.
You mentioned that there are 4 or more medications available. Is any one of them better than the other?
Yeah, so there's a notion of something that's called first line, and what we mean.
Sorry to interrupt. Did everybody hear that question? Could you hear that, or did you want to repeat it? Just so
Sure. Yeah, Ed was asking about there are the number of medications that we have available to us, and how do you know which one's best, or is there one that are some that are better than others? And there are some that have better evidence to support their use. Meaning big clinical, we've all heard the term clinical trials, so big trials with thousands of people that are double-blinded and not biased, and that do support that, yes, that medication is effective at treating alcohol use disorder. So the two first-line medications that we have available would be acamprosate and naltrexone, both commonly used and pretty much widely would be known by most primary care providers, I would say, certainly coming from a bias standpoint being in this group, but I would hope that everybody would know about those medications. And then there are other medications as well, gabapentin, topiramate, baclofen, and ondansetron, that might actually work better in certain people than the first line agents, but don't have as robust evidence to support that. So as big of clinical trials, blinded, etc. So these things always do change, just as I'm sure you've all experienced over your life when some provider told you that this was the best to treat X, and next time you went to the doctor it changed. Things do change and things do evolve as we get more information about these and more people engaged in treatment. So.
Great, thank you.
How much do these medications cost, or is that covered by something?
Yeah, so that's a great question. So both acamprosate and naltrexone are covered under Fair Pharmacare. So any provider, and there used to be a special piece of paper that a provider would have to sign if you wanted to prescribe these medications to get them covered for your patients, but that has now, I think with the help of you guys actually advocating for that, so the government has waived that, so those medications would be covered for everybody. Second line agents, topiramate and gabapentin, are really cheap in the grand scheme of medications, but I don't believe have the same drug coverage. Do you guys know?
I think it was naltrexone or camprosate.
just naltrexone and caprosate that have the fair firm care coverage yet. But as from my experience, I mean, gabapentin and topiramate have many other indications, and in terms of a cost, like I do have a lot of patients complain about costs for various inhalers for their COPD or diabetes medications. I have never had anybody complain about the cost of gabapentin for any condition that I would use it for. So.
Thank you.
I was just wondering, how long would a person expect to be on these medications?
Sure. Yeah, these are great. These are probably the same questions you have written down.
Perfect.
So I think that's a very patient-centered question. So I specialize in medicine that I treat the patient in front of me, and it's the diseases that come and go. So I tailor my treatment to you as an individual, and you may be different from your partner, from your friend, from your family member. And I think that's where the nuance of being a family physician or a primary care provider is really understanding the values and wishes of that individual, understanding their social situation, their employment situation, their past mental health experiences, their past experiences with substance use, and trying to engage the patient as a kind of shared decision-making team on how long that might be a good fit for you. Some people are very motivated to limit the amount of medications they're on for the shortest amount of time, and others want to, I'm happy with the stability that I now have, that I'm not drinking, and I'm more than happy to take a medication if this gives me that extra little bit of support to abstain from alcohol.
I wanted to introduce Ninka's story, who I thought maybe could help with answering that question. I wanted Ninka to talk a little bit about her experience and how she learned about this, and how long she was on the medication for, and what recovery meant for her. So maybe that will help.
Yeah. Good evening. I have AUD, which sounds much better than telling people that I'm alcoholic, so I like that. I started taking naltrexone in April last year, and I started with 2 pills per day, and after 3 days my cravings had totally stopped. It really was incredible. Before that, I started thinking about happy hour at 2 o'clock or 3 o'clock, thinking, what shall I have first, a glass of wine, or shall I have a Caesar, which is one of my favorite drinks. And then eventually I found myself, I thought, oh gosh, I drank a whole bottle of white wine. Oh well, it's only white wine, that's okay. But I did realize that I was alcoholic. I did not feel that I would be suitable for AA. I also did not want to stop drinking totally. So with naltrexone, you can still drink your glass of wine, but after 2 glasses of wine now I feel I don't need to drink anymore, and I don't have that cravings anymore. They're totally gone. And there were no side effects. The first 3 days or 4 days I felt a little bit woozy, and I had some, what do you call it, brain fog. But I understand now, I learned later that if you take a high fiber and a high nutritious, high fat diet for those first few days, that helps with the brain fog. And so after 1 year, I stopped taking, I tapered down to half a dose, and then April this year, I stopped totally, and I haven't gone back on it. But with naltrexone, you can go back on it when you feel that you're slipping back and that you're starting to drink too much. You can also, with naltrexone, if you're going to an event and you're afraid that you will start drinking too much, I understand that you can take a pill before you go, right? Am I correct in that? Andrew?
Correct? Yeah.
That's correct, okay, good, yeah. So I keep a little bit of medication at home just in case, and I know I can always go to my physician and ask for more if I feel I need it. But so far, since April, and I think Ed can attest to that. We have our happy hour, but with non-alcoholic drink. But for special occasions, when I go out for dinner or so, I have my 1 or 2 glasses of wine or a Caesar, and that seems to be just plenty for me.
Thank you, Nika. And so we're giving you a complete answer, and I'll get to some of your other questions. I see hands up, but I know that Lori had something to add to this.
Just about the question you had about the wine mom that felt that she was cured. We have a group of people that come together that have lived experience with AUD, and one of the interesting conversations we had just recently is, do they feel like they have kind of a chronic condition like diabetes, congestive heart failure, so you take your treatment, but you have these medications, and then should you have a relapse, you can go back on and get back stabilized. So some people like to consider, they have a chronic disease and they may be symptom-free for a long time, but they always know that this is a treatment that they can have afterwards. Others, like that woman on the video, feels she's recovered, and that's how she wants to look at her past treatment. So we've got both.
Thank you. And just before I take those 2 questions, which I promise I will get to, we've been talking a lot about the individual themselves who is suffering from alcohol use disorder. And I just wanted to make sure that we addressed, and I was going to ask Karen this, how do we talk to others about this? How do we approach the subject with a family or a friend? Or if you have advice for meeting someone where they're at, or managing expectations for people you saw this film and this could help, but they're not ready. So do you have any advice for that?
I think my biggest advice is just to be kind, always be kind, and be open-minded. Opening that conversation and providing a space for somebody, just listening, right? If you ask that question, asking a person how they are, meeting them where they're at, and providing that space. If they come to you and they want to talk in that moment, then that's great. If not, no pressure, right? You've opened the door, you've planted that seed, and even using those I statements too, talking about how you experience alcohol use or drinking alcohol, or that's always good to share your experiences with other people. That'll open the door as well. Yeah.
You had a question.
Yes, I'm just curious, I know BC does, but these medications, are they available across all jurisdictions in Canada?
Lori, you're the perfect person to
Great
answer.
question.
If you want to repeat it, that would be great.
Are these medications available across Canada? So about the time that Jeff started this, if you went into your physician, your odds of getting an appropriate medication was about 1 in 100. So that's not very long ago. You're very privileged of being here in Princeton because all of the physicians practice in this way. And Jeff traveled across BC and was instrumental in the BC guidelines. Now, as of October, there's new national guidelines for clinicians with these same medications that are being spread and taught across Canada. And we're very privileged with Canadians because we've just had a colleague come up from the United States, and the US does not have that kind of universal widespread knowledge yet. So.
The reason I asked the question, I've spoken to Nanki on the phone roughly 6 months ago, and I spoke with my family physician in Nova Scotia.
Good.
He is about 85 to 88, I don't know, he's very old school, and he said, and I mentioned the drug, and he said it's unsubstantiated. So I just wondered, and he didn't say any more, he didn't say, yes, it's good, it's bad, it's unsubstantiated.
Did you want to
That's
talk
what he
about
said.
how you speak with colleagues or how to address that?
Sure, yeah, so I argue on the contrary, like I think, you know, we, especially as general practitioners, you cannot be a master of all medical conditions, period. It's just so many things to know, just as I'm sure all your professions are the same. It is very challenging to be a master of all. So we do rely on organizations such as the Canadian Alcohol Use Disorder, Diabetes Canada. There's another organization for blood disorders called Thrombosis Canada. We rely on these organizations, which compose of very motivated individuals who have the expertise to analyze all the data and research that's coming out and present us with evidence-based, concise guidelines that
Please don't think I'm saying anything negative at all.
No.
No.
Just
We're not.
He said to me,
Yeah.
and he's 88,
Yeah.
and I'm very, very old.
So, and I think a part of probably what comes from that
He might
is,
not know anything about it, and that might have been just his answer on the
Yeah.
telephone when I'm speaking to him.
and I think that's probably just, exactly, lack of knowing at this point, right? So we're in the process, and I think that's a big goal for our organization, is to help disseminate that information. When I first started getting involved in the Canadian Alcohol Use Disorder, a lot of the initiatives were geared towards medical providers and educating medical providers. Now, as events such as this, we're starting to engage the community members and raise awareness from that standpoint. And all of these, and I would say this condition more than many others, it takes two to tango. So this is something I think about all the time and screen people for regularly, and I have a practice of about 1,000 people, and every day I identify people who drink way more than I even realized, despite screening them, despite asking them in multiple ways. They just didn't feel comfortable or ready to share that information with me. So it does take two to tango. So it takes knowledge from your care provider, and it also takes knowledge from the community member as well. So I think this is where organizations such as everybody in this room who are engaged in wanting the best for their colleagues and family members and neighbors and community members, they want the best for them, and hopefully we all as leaders in our community can share this information with others, and maybe your primary care provider will say, that's the second person who's asked me about that now. I should do a little research and pull it up and maybe learn something new. So you may have very well helped a number of other people in his practice already without even knowing it about this. So.
What a perfect answer. Did you want to add something?
We do have a letter on our website that introduces and has some research for anybody that's going to visit their doctor. I don't know how that's always appreciated, but we put that there for exactly that example. If you're elsewhere in the country and your doctor is unfamiliar, this is a starting point for conversation.
Good question, and I appreciate that.
Great. And then just one more thing to add with Interior Health Authority, one of the things that they've been promoting and moving towards is that every door is the right door. So when you're struggling with alcohol use disorder or any substance use challenges or mental health challenges, it might be your family doctor, it might be if you're in the emergency room. You might be in the emergency room because of something else, but when you walk into that door and you're involved with the health authority and there's a nurse or there's a social worker or a physiotherapist, any one of those clinicians can be someone that you can talk to about this, and they'll help direct you into the right place to get the help that you need. And with the health authority, there's a few different options. There's ways that, depending on the level of drinking, you might be able mild to moderate, where a medication might be able to support you recovering home. Or there's another program called Outpatient Withdrawal Management. We don't have it here in Princeton, but in the bigger centers in Penticton and Kamloops and Kelowna and some other places, if you need detox in order to stop drinking, because alcohol can be quite dangerous to just stop abruptly, there's a program where you can do that in the comfort of home. Now, like I said, we can't do that in Princeton, but if you have family or friends in Penticton or Kamloops or Kelowna, you can go and stay there, and you'll have nursing support daily that'll be there to support you, and then it's a whole healthcare team there that you get the prescriptions that you need to detox effectively, and if it escalates where your health is becoming unstable, well then you have that hospital option there. But then there's also detox facilities, and there's rehabilitation and recovery support beds in Interior Health too, if you need more in-depth counseling to help support you in your recovery. And like Dr. Ashley said, recovery is unique to each individual, right? So those options are there for you.
Thank you so much to our panel. What a wealth of information and different experiences that you've brought that I think have really helped shape the conversation and get people thinking about this in a new way. So I'm just going to ask before we go if there's any other questions, or if anybody on the panel has some burning thing that I forgot to ask you that you would like to share. Going once. Going once. Oh, to Ninka.
For Dr. Ashley, last week I received an email from a Princeton resident who knows that I'm using naltrexone and who wanted to get the medication. However, he's on a waiting list for a doctor, and he cannot get into a Cascade clinic for just that. So do you have any suggestions that I can give back to him?
So this is very obviously specific to our clinic in Princeton, but so we do have a wait list at our clinic. Hopefully we'll have everybody attached by in the next month. We do every month attach people as physician's capacity allows. Once you have your, we call it RFA, request for attachment, once you have your paperwork and you're on our wait list, you do have access to primary care. So we do have what we call locum physicians, who are kind of substitute doctors that come periodically to our clinic. 1 or 2 weeks a month, we typically have a locum physician. So people who are on the wait list can seek care from the locum providers. If you're flagged as, if you were on your RFA, if you specifically say, you're looking for support for alcohol use disorder, opiate use disorder, some sort of substance use disorder, you will be flagged as what we call a triage 1, and you'll get attached within the month. So that would be another way to go about that. Often when I hear these stories, we just don't know about these people. So it's challenging to, and if they're identified, or they raise their hand, or, a supportive community member brings them up there, we will see them. Myself, Karen, we see people same day all the time for various issues. So I'm more than happy to help these people, but it's just trying to navigate that with the sea of all the other visits for various medical things we're trying to deal with. But we do try to prioritize people with substance use disorders, just knowing that sometimes the window that they're looking for help is a short one. So
Great. Okay.
maybe I guess you said
Yeah.
that burning thing. One last thing I didn't emphasize, but I know has been emphasized from us in that video, is really emphasizing the point about, there's many ways to look at success. So abstinence isn't the only success, it's not binary. And that really, truly, probably is the most important thing I want to stress to everybody. If you drink 6 beers a day and you cut down to 4, that is that's something we're going to celebrate together. That is great. You've cut your consumption down significantly, and that is something to celebrate. You may not want to stop drinking alcohol altogether. That is okay too. So just emphasizing that point that your values and wishes are most important, and as care providers we will respect that and work with you to reach your goals. And sometimes your goals aren't the same as other people's goals, and that's okay. Those goals can always be revisited down the road.